Hello, my name is Abby and I'm a dietetic intern here with Providence Regional Medical Center Everett at the Colby campus, a student from WSU, talking about the importance of charting PO and supplement intake. Because if we are to make progress towards improving nutrition care practices, especially ones that guarantee every malnourished or at-risk patient is identified and treated effectively, we must proactively identify barriers impacting the provision of nutrition care as a team. I have no disclosures, and the objectives of what we'll go over today is interdisciplinary nutrition care, which is kind of woven in throughout the presentation, the why, impact of nutrition interventions, key nutrition principles, and then lastly, calorie counts. So here's a quick flow sheet of interdisciplinary nutrition care and how it is involved from the time a patient is admitted to their discharge. And as you can see, a nutrition risk screen is completed by nursing staff, as you know, within 24 hours using a validated tool from the hospital. And these results are then documented within the EHR so that dietitians are therefore able to go in, see if a person is at risk for malnutrition or is malnourished. Therefore, we can go make an assessment, document this within the EHR, diagnose it, and the physician can agree or disagree. A custom nutrition care plan is created and ordered where nursing staff is documenting this, helping the dietitians see if they're having adequate or inadequate nutrition intake, whether it be from supplements or meal trays or both. And we are involving the patient and family education, if applicable, to help when it comes to discharge, where nutrition is involved, helping the patient in their discharge so that they are able to have a lower risk of readmission, mortality, etc. The why. A food record chart aims to record quantitatively all food and drinks consumed as accurately as possible. Of course, there are fundamental problems with this type of assessment, and this may include the interpretation of portion sizes. For example, writing ate a big bowl of cornflakes doesn't really provide a sufficient information to go off of and estimate nutritional intake. A more accurate measurement is required, such as patient consumed 75% of cornflakes or consumed 1 cup of cornflakes with whole milk. Reliability of the information is another potential problem, owing to the inclusion of food that's not actually consumed or omission of foods that were. In some situations, patients may or may not be willing to provide accurate information. And it's also important to note that malnutrition be diagnosed when at least 2 of the following 6 criteria are identified. You can see here, but I think the 2 most important ones that relate to nursing are when it comes to insufficient energy intake and weight loss. This is why we constantly need weights taken from the patient so we can see any weight trends that are happening. And if they are having insufficient energy intake, meaning less than maybe 75% of their needs or 60% of their needs, we can go and recommend a tube feed or TPN, whatever is going on with the patient. The impact of nutrition interventions. Nutrition intervention strategies represent a broad spectrum of options that can be organized into 4 different categories, which would be food and or nutrient delivery, education, counseling, and coordination of that nutrition care. A meta-analysis of 4 randomized trials showed that in patients with no pressure ulcers at baseline, high-protein ONS resulted in a significant 25% lower incidence of ulcers compared with that routine care, whereas it may be just a normal hospitalized diet. When it comes to a length of stay, a prospective study conducted at the Johns Hopkins Hospital, nutrition screening involving a team approach, including nursing, dietitians, and physicians, to address malnutrition and earlier intervention, reduced the length of hospital stay by an average of 3.2 days in severely malnourished patients, which translates into substantial cost of savings of about $1,514 per patient. Another prospective randomized trial in acutely ill patients 65 to 92 years of age demonstrated a significantly lower 6 months readmission rate among those who received a normal hospitalized diet plus high-protein ONS, comparing with those who only received the normal hospital diet. And lastly, when it comes to mortality, an overall 24% reduction in mortality with patients of a lower average BMI of less than 20 receiving ONS had a greater reduction in mortality. There are 6 key nutrition principles that I want to outline here. Number 1 is creating that institutional culture. It is the fact that nutrition improves patients' outcomes, and that's why it is, again, so important we're accurately recording how much a patient is consuming with meal trays, supplements, or what the tube feed may be running at, etc. Failing to prioritize nutrition may limit optimized care. We discussed earlier about pressure ulcers and how oral nutrition supplements help the outcome in these patients, or mortality, readmission. And everyone must be educated in recognizing malnutrition. That's when it comes to screening patients and making sure everyone in the care team knows what is happening. Principle 2 is redefining clinicians' roles to include nutrition. That means engineering daily team huddles to include nutrition, discussing about how much the patient is consuming with supplements or meal trays, ensuring practices are in place to support nutrition interventions, and then dietitians are to regularly participate in these rounds. Principle 3 is recognizing and diagnosing all patients at risk. We discussed this earlier, and rescreening patients weekly if they are not malnourished or at risk. The 4th principle is rapidly implementing interventions and continued monitoring. At-risk patients found during the screen are to receive nutrition interventions within 24 hours, being documented frequently within flow sheet. Communicating nutrition care plans is number 5. Consulting a dietitian if there are any concerns regarding PO intake, the rate of the tube feed, if a patient is not tolerating, etc. And then in handoff care, discussing what's going on with the patient regarding nutrition. And the last key principle is developing a discharge nutrition and education plan. Nutrition should be a component of all clinician conversations because it can reduce the risk of readmission, mortality, improve wound care, etc. Lastly, I want to discuss this calorie count handout on how to do calorie counts properly, because the information of a patient's food intake is required in clinical practice for the evaluation of energy and protein intake, implying possibly a need for a supplement, a revised nutrition plan, or a consultation from the clinical dietitian. The dietary record form is a mandatory tool for monitoring this intake, because monitoring food, as we've said, can identify early in the prevention of nutritional decline in patients with poor intake during hospitalization, and has been recommended in various guidelines. And so when we get these food receipts from the kitchen, we're recording the percentage consumed next to each food ordered, including supplements. If something is not on the tray, we're documenting it on that sheet that is provided on the door in a table format. It's very quick, very simple to do. And if we just take a little bit more time to fill out this calorie count, it saves so much more time in the long run when it comes to caring for this patient. If you have any questions, please feel free to email me at abbyroberts@wsu.edu. Thank you.